be on our website. If you go to your class, there's a class guide.
There you go. Thank you.
Well, I'm just saying there's
Hello, good morning. Hello. All right, I'm back again, and we have 1 hour, and I'm going to try to go through things quite steady, systematically, and hopefully you'll learn something at the end of the hour. So this is going to be about HIV-AIDS, and I'm start off with some introductory slides, and then I'm going to spend quite a bit of time talking about the opportunistic infections. And towards the end, if we have any time, I've thrown in a little public health in that as well. So this is just a schematic of the life cycle of HIV. Don't memorize it. It's only just something to help you understand what's going on. So you know it's a RNA virus, and the virus gets into the cell. It's the CD4 cell, makes a lot of copies of itself. The binding and infection, followed by reverse transcription and integration of the viral DNA into the host nucleus. Then you have transcription, followed by modification, translation, assembly, and then budding and final assembly, where billions of the virus is released. In the process of doing so, the virus kills the cell, hence falling the CD4 cell count over time. So just some basics, so we're all on the same page. So to be HIV positive means one must have a confirmed positive blood, urine, and saliva test, and that this state can last 7 to 10 years or longer, and I'm going to show you examples of where it's longer or shorter, but the person may appear completely healthy. Also know that the HIV positive patient can unknowingly infect another person, and it causes changes in CD4 and HIV viral load. One of the questions I get asked a lot by patients is, where is HIV in my body? Well, short of it all, it's everywhere we've ever looked. Every cell type that has a CD4 receptor, brain, lymph nodes, thymus gland, lungs, skin, bone marrow, the intestines, we have been able to locate the HIV virus. Certainly there's some compartments that have more of the virus than others, but certainly everywhere we've ever looked. So what does it mean to be AIDS? And this might sound very basic to you, but patients actually take this quite seriously. If you were to call someone who thinks they're HIV positive, say they have AIDS, they take it quite personal, because AIDS is associated with the end stage of the disease. It's highly infectious, and the person could appear completely healthy. But if you were to tell a patient that they have AIDS, when they say they're HIV positive, you're basically telling them they're going to die. That's how they interpret it. So understanding the difference between being HIV positive and AIDS is an important distinction. So CD4 T cells, the cell type in the body that HIV infects and destroys, it tells us how strong the immune system is. Normal levels are 500 to 1500, and below 200 someone has AIDS. It's associated with certain diseases when low. Here's the natural history of HIV in an untreated patient. Here's CD4 on the y-axis and time in years on the x-axis. And you can see normal is about 500 to 1500, and then over time, CD4 gradually falls. CD4 count falls anywhere from about 70 to 100 T cell counts a year. So you can get a rough estimate based on what someone's T cell count is when they're likely to be infected. Now, it's not exact. Don't tell them what I said. That's how you're going to calculate it. It just gives you a ballpark of when they're likely to be infected. So that if someone comes in with a T cell count of 200, you can be reasonably safe to say they were infected maybe 7, 8 years ago. So as CD4 falls, it becomes associated with some things called opportunistic infections, some of which occur early, and others which occur late, when the T cell count is very low, usually under 200. So CD4 T cell, we use CD4 T cell as a laboratory marker to determine when to start medicines, highly active antiretroviral therapy. And the present guidelines say we start therapy when the T cell count is under 350. We follow it constantly while the patient is on therapy. We should increase if therapy is effective, and the trend is reversed if the patient is not compliant with medicines. Viral load is also the other laboratory parameter that we follow when someone is HIV infected. It measures the amount of virus that's in the body, and if you're not infected, it should be 0. Certainly you can get some false positive numbers, but those numbers are usually very low. Come back at 400, 500. What you do is you wait a few, 2 or 3 weeks, and you repeat it again. Right? But if someone is truly infected, it can be very high. It could be as high as 750,000, and that's only because that's where the test stops. It could be as high as 1 million. It's also used when to determine when to start medicines, highly active antiretroviral therapy, and according to present-day guidelines, it's when the viral load is over 100,000. So 2 things to decide when to start therapy. 1 is CD4, 1 is viral load. Actually, the 3rd thing is when the patient wants to, right? I think I said that. Okay, so the goal of CD4 is to get it as high as possible. The goal of viral load is to get it as low as possible. When it's below 400, we say that the patient is undetectable. It's important to know and to communicate to the patient that undetectable does not mean uninfected. A lot of times patients will interpret being undetectable as, oh, I'm cured, or no need for a condom. Now, even when you're very low, viral load, you can infect someone else. It's much less likely, right? And that's evidenced by when a woman is pregnant and we place her on antiretroviral therapy. The goal is to get her viral load below 1,000. It makes it much, much, much less likely that she's going to transmit infection to her baby. And the same thing during sexual transmission. But it's not 0. Very, very crucial. One way to look at viral load is, here is death. And we all die, so don't be surprised. But you could either walk towards your death or you can fly there, right? And since you don't want to die early, whatever that is, you can go at 1,000 miles an hour or you could go at 100,000 miles an hour, right? You want to go as slow as possible. So the higher the viral load gives you an indication of what the person's lifespan is going to be like. This is also another important concept. It's the window period. It's a time during which a recently infected person will have a negative HIV test. It could be up to 6 months. Associated with a very high viral load, can be associated with symptoms, and because of very high viral load, condom use is required. It's important to be able to communicate this to a patient. What happens sometimes, we're like working in the STD clinic, someone will present in January and have did some risky stuff, and present to the clinic in January with a negative HIV test. And you say to them, well, come back in 6 months to get a repeat HIV test because the window period is 6 months, right? But if a person did something risky April, May, June, you have to reset the clock. And 6 months after that, not 6 months from January, but 6 months from May, because you will tell them that they're negative. They would have been negative January, did something in May, and the test in June is negative. You tell them they're negative, only to find out a year or 2 later they're HIV positive. Right, because they did something before. So you start from the last risky period, 6 months out. So the natural history of HIV is that AIDS is very rare in the first 3 years after seroconversion. Most people stay HIV positive and they'll come to that thing in the next slide 7 to 10 years later. But there's about 10% of people who can crash and burn in the first 3 years. There's a case in New York about 2 years ago where someone had a negative HIV test, like April, had another one, September, and then got sick, had one in November, and had AIDS. All right? But that person represents less than 1% of all people. So it is possible that someone can progress quite dramatically when they're first infected. And as it says here, the HIV ELISA, enzyme-linked immunosorbent assay, may be negative during acute retroviral syndrome. So what's acute retroviral syndrome? It's a seroconversion for HIV in the initial stages, right? Here are the most common symptoms, very important to know. Fever occurs about 80 to 90% of the time. Fatigue, about 70 to 90% of the time. Rash, about 40 to 80%. Headache, 32 to 70%. Lymphadenopathy, 40 to 70%. Pharyngitis, up to 50 to 70%. Those are the major symptoms. And doesn't it sound familiar? It sounds a lot like mono, right? Sounds a lot like mononucleosis. It sounds a lot like what you get when exam times are coming around, right? But then there are other stuff: muscle ache, night sweats, GI symptoms, aseptic meningitis, oral or genital ulcers. You have a group of patients who have no idea when they seroconverted, but there is a significant amount of patients who can tell you when they seroconverted, and they'll tell you because they say, gee, I remember a year or two ago, I had this fever, I felt so tired, couldn't work, had a rash all over my body, or I had sore throat. They were seroconverting. And what happens is that they go to y'all, the doctors, and you think, oh, mono, right? Or, get some rest, eat right, and exercise. Or you order an HIV test and it comes back negative, and you send the person home. During this stage, a person is extremely infectious because they have a very high viral load. But they're seroconverting. So it's important to include in your differential anyone who comes into fever, fatigue, rash, headache, lymphadenopathy, pharyngitis, arthralgias, myalgias. Think of acute retroviral syndrome. Okay. The time span to develop AIDS, as I said, is years, and by the time you get overt AIDS, there are severe constitutional symptoms, opportunistic infections, and neoplasms. Any questions so far? Uh-oh. Acute retroviral syndrome. It's a flu-like syndrome. It could be like a week or 2 weeks. A week or 2 weeks. When someone has AIDS, sometimes the same things can last for several weeks. But in the beginning, about a week or two. And will just quickly disappear just as how it came on. Question in the front and then question in the back. You.
So you mentioned the acute case of the reinfection.
Uh-huh.
The test does not show negative.
Okay.
So I have a hard time understanding the reinfection. Why can't
Yeah, I'm glad you asked it. You're thinking. I appreciate that. So the standard test for HIV looks at antibodies, enzyme-linked immunosorbent assay. So when someone gets the antigen, they have to form antibodies. So remember, you have to start off at 0, right? You start off at 0 until your antibody levels rise. It turns out, based on the sensitivity of the ELISA, depending on where it catches your antibodies, it's rising. It's not going to catch it when it's, let's be simplistic, 0, 1, 2, 3, 4. It might catch it when you're 10. So anybody who's 10 and above, the test is positive. If you're 10 and below, it comes back as negative. That's why you got to wait time for it to come up to 10. The test, if you have a high suspicion of someone being acutely HIV infected, is a viral load. You do a PCR, polymerase chain reaction. And in fact, the FDA last month approved a PCR qualitative as an HIV diagnostic test. So it gives you a yes or a no. Right? So now you can send off a PCR without getting in trouble. In the old days, back in the bad old days of the 80s, if a patient didn't consent for an HIV test, what people would do, and I won't say who, but what people who are doctors would do was send like a CD4 count, right, or a viral load. Now you can't get a HIV test without consent. We're trying to change that. And until last month, you couldn't order a viral load without an ELISA, without an HIV test. So yes, if you have a high suspicion, you first send a standard or rapid HIV test, and if that comes back negative, then you send a viral load. All right, question behind. I'm going to show you the rash. Yeah, it's not pathognomonic, but it's obvious. But I'm going to show you a picture of it. All right. Any other questions? Okay. All right. So most people, about 80% of people, are typical progressors. They become HIV infected. It takes about 7 to 10 years to develop AIDS, and this shows a decline in the CD4 count and how the viral load is initially very high, then falls to a set point, and then from your set point, you increase over years. The set point is important because if you are initially high and you fall to almost 0, undetectable, then when you start progressing towards AIDS, it means you have a longer time to get up to AIDS if you have a low set point. If you have a high set point, then in a few years, you develop AIDS. So if you're going to get HIV infected, you hope your body works with you and give you a very low set point. There's some people who, as I said, are rapid progressors, about 10% of people, and less than 5% develop AIDS within 3 years, 3 to 5%, and they are rapid progressors. But you do have a subset of people who you'll meet in the public, in the hospital, say, gee, I've been HIV infected for 10, 15 years and never been on medicines. And there you check their values, the lab tests, HIV test is positive, but their CD4 count remains very high, and some of them, in fact, have undetectable viral load. It's a big dilemma for us, but it does happen. Being a non-progressor doesn't mean you're not in care. You still need to see the doctor. still need to come in because you need to get counseling on prevention because you can go and infect someone else, even though you're not on medicines and we're not drawing the labs as frequent. Also, another thing you should know is that you can move from this to this or from this to that, right? So you want to keep seeing the doctor so we can follow your CD4 and viral load to assess when it's going to be time to start medicines. Yeah, we don't know. If you work on that, you win the Nobel Prize. We don't know. We don't know what slows some people down or speeds some people up. There are also a cohort of prostitutes, I think in Nairobi, Kenya, somewhere in Africa, who are HIV positive, have sex with many people who are HIV positive and never themselves become infected. We don't know. Not me, but scientists are looking into answers for that. It's a good question. The back. Yeah, there's some people who can have, so the CCR5 or CXCR4 are co-receptors. In addition to CD4, the virus binds to CD4, but also binds to other receptors on the cell to get in. But no real correlation to generalize. In a subset of people, maybe, but it's not definitive as yet. Because it would be great, because if you knew that's what it was, then that's a vaccine target, right? But, the fact that we're zillions of years from vaccines demonstrates how really difficult it is. So the acute retroviral. So someone asked about the rash. So here's a diffuse maculopapular rash. Now this looks just like secondary syphilis. All right? This looks just like secondary syphilis. So it's not pathognomonic, but it's noticeable. If the person notices it, right? Because sometimes it could be fleeting. It's really hard. But someone who has it will tell. And this is what it looks like. Thrush can appear very early. This thick cheese-like material, right? You don't have to have AIDS to develop thrush, which is candida or yeast. So someone will wake up one morning, one evening, one night, depending on what you do, and notice this, and say to you, what's going on? Think HIV. You can also get this in situations where someone is on steroids, inhale steroids or for cancer, chemotherapy, and so on. But if someone is 22 years old and healthy appearing, certainly think HIV when that shows up. So opportunistic infections occur when immunosuppressed, increases with decreasing CD4 count. There are medicines available for prophylaxis that you can talk about, so PCP, Toxo, BAC, and there increases chances of complications and death. In fact, most of the patients used to die from HIV in the old days didn't really die from HIV-AIDS. They died from the complications of OIs. A lot of patients presented with an opportunistic infection. So which is why we're encouraging getting an HIV test. I'd rather you find out you're HIV positive when you're healthy than when someone has to call 911 because you have PCP, right? And the chances that you're doing well is really not good when you're diagnosed that late. So here, questions. Oh, pneumocystis carinii pneumonia. All of these things I'm going to go through. Well, not all of them, since we only have an hour. But I'm going to talk really fast. Okay, so I'm going to tell you about all of these. And I'm going to touch on the important ones. Now, I should also point out that because highly active antiretroviral therapy is so successful now, you're rarely going to see some of these. If you practice in South Carolina, yes, you will, because we are a little below the curve. But if you go to somewhere where they're really up and all the patients are on medicines, these don't appear that often. But this is why it's so crucial now to understand what it is. So you're called AIDS if your T-cell count is under 200. But you're also categorized as AIDS if your T-cell count is over 200 and you have any of these. Right? So your T-cell count, you could get HIV infected yesterday and you develop thrush, which is candida, of the esophagus, trachea, or lungs, invasive cervical carcinoma, extrapulmonary coccidiomycosis, fungal disease, extrapulmonary cryptococcus, fungal disease, cryptosporidiosis, greater than 1 month because you get diarrhea. We're going to talk about this in a second. But even healthy people can get crypto or coccidio. CMV cytomegalovirus retinitis, extrapulmonary histoplasmosis, a fungal infection, HIV-associated dementia, and there's HIV wasting down here, Kaposi sarcoma, certain lymphomas, disseminated mycobacterium avium complex, or MAC, tuberculosis, PCP, recurrent bacterial pneumonia, progressive multifocal leukoencephalopathy, PML, recurrent salmonellosis, toxoplasmosis. We're going to talk about some of these in detail. But this list is important to know because classical, they'll give you someone who has a T-cell count of 400 or 500, who keeps coming to the emergency room 5 times with recurrent pneumonia. And you think, oh, they just have a pneumonia. They have HIV, which is making them susceptible to having recurrent pneumonia. So guess what? You treat pneumonia, the patient ends up dying, right? So you always want to keep those things. All right, so here's the natural history of HIV infection. As I pointed out, you can get some of the opportunistic infections very early when your T-cell count is really high. So things like thrush, which is yeast, oral hairy leukoplakia, which I'm going to talk about in a second, tuberculosis. Anyone who's diagnosed with pulmonary tuberculosis is an indication for an HIV test. Anyone who gets diagnosed with tuberculosis is an indication for an HIV test because tuberculosis is a more rapid progression in someone who's HIV infected. And secondly, the medicines that you use to treat to treat tuberculosis interacts with the HIV medicines, right? Causes changes in the level. So you got to know, what are you going to treat first? Are you going to treat the HIV first, or are you going to treat the TB first? But if you never check for HIV, you'll have no clue, so you've got to check for it. PCP, histoplasmosis coccidio, cryptotoxo, atypical herpes simplex virus. Herpes is usually restricted to the genital, oral and genital area. But if you're immunosuppressed, it could be, you get the sores all over your body. In your body and outside your body. Really horrible. Cryptosporidiosis, CMV, and MAC. MAC tends to occur when your T-cell count is very low, usually around 50 or less. All right, so now we're going to go through some of the opportunistic infections and the CD4 counts where they typically occur. And notice I said typically occur. If your CD4 count is over 500, here's some of the infectious things you get. So acute retroviral syndrome, Candida vaginitis. You'll have some women who present with recurrent vaginitis that just doesn't get better no matter what they do. Now, I should quickly add that a woman can have recurrent vaginitis from Candida and not be HIV infected. But certainly if she keeps having it, you should certainly think about HIV. Other symptoms that occur with a T-cell count over 500, the generalized lymphadenopathy. You have some patients will come in and say, you know, doc, I notice I'm having some swelling here and in my groin. The generalized lymphadenopathy. That's where the virus is replicating. Guillain-Barré, which is very rare, ascending paralysis, and vague constitutional symptoms. I feel sick, I feel tired, I feel weak, I can't study, I can't concentrate, nobody loves me, nobody cares. Think HIV, all right? Think about it. Okay. So here, if your T-cell count is between 200, so everyone here should be tested, right? Your T-cell count is between 200 and 500. Some complications you can get is pneumococcal pneumonia. Anyone, particularly any young person, and young is anyone my age and less, right, who gets recurrent pneumonia, should be tested for HIV. If you're over 65, that's typical, but even over 65 should get an HIV test anyway. But if you're a young individual, you shouldn't be having recurrent pneumonias unless you have some immune stuff going on, all right? But recurrent pneumococcal pneumonia in particular, think of HIV. Tuberculosis, as I pointed out, herpes zoster, okay? If you develop Kaposi sarcoma, oral hairy leukoplakia, which I'm going to talk about in a second, oropharyngeal candidiasis, thrush, some non-infectious things, cervical cancer, some lymphomas, an ITP, immune thrombocytopenic purpura, where the person present with very low platelet count, prolonged bleeding, easy bruising, right? There's idiopathic thrombocytopenic purpura, but it certainly occurs in HIV as well. And sometimes you just notice that you send off a CBC, a complete blood count on someone, and all you see is the platelet count is really, really low. Think HIV as one of the reasons. And these people tend not to have splenomegaly. They not have splenomegaly, and look in their bone marrow, they have a large number of megakaryocytes, which suggests that it's peripheral destruction as opposed to central destruction. Okay. So oropharyngeal candidiasis, thrush, limited to the oropharynx. Esophagitis is more serious, usually CD4 less than 100. It's associated with odynophagia, which is pain, unswallowing, or chest pain. Someone might just come in with if you have a 25-year-old, male or female, having left-sided chest pain, and there's no family history of an MI, of a heart attack, think HIV, because they might not have the thrush in their mouth, but they have it in their esophagus where you can't see it, and it's presenting with chest pain, or it might feel like heartburn, think HIV. Other causes of esophagitis that can occur in someone who's HIV infected is cytomegalovirus, usually with a T cell count under 50, or idiopathic ulceration with a CD4 count less than 50. It looks like aphthous ulcers. The ulcers are painful. They're treated with steroids or with HIV meds. But those are other reasons why someone can have esophagitis. Here's what it looks like. And this is not the stuff when you wake up tomorrow morning without brushing your teeth that you see in your tongue, so don't freak yourself out. It looks like Philadelphia cream cheese. I mean, it's really thick and yuck. Like that. All right? So that's in someone's esophagus all the way down. It's really noticeable. Here's candidiasis. What's this am I looking at? So these are the yeast forms, the pseudohyphae, the long filamentous form. And this is a pap smear, I believe, and it's a 10% potassium hydroxide, a KOH prep. And the mucus can be really thick and cheese-like, or it can be thick and thin and watery. So oral hairy leukoplakia is caused by the Epstein-Barr virus, and no treatment is required. It looks a lot like thrush, but how it's distinguished from thrush? Well, it's white. It occurs at the corner, the vermilion borders. It occurs at the corner of the tongue. And unlike thrush that you can scrape off, thrush you can scrape off and it won't bleed. But if you try to scrape off oral hairy leukoplakia, it will bleed, and it will hurt, and the patient will punch you. All right? So don't try to scrape it off. But it occurs right at the border, and it's whitish, looks like thrush, but cannot be scraped off. Kaposi's sarcoma. Clinical manifestations are variable in HIV, usually cutaneous or oral, but visceral involvement also occurs, so in the gastrointestinal tract or the respiratory tract. And the causative organism is another virus, human herpes virus 8, HHV8. Here's what it looks like. So these purpuric lesions, the black and blue blotches that bleed easily. Kaposi's sarcoma is very vascular, just looking at it makes it bleed. Very highly vascular lesion, literally. Here it is on someone's feet. Here it is this is a chest CT. Here it is in the lung. And this person is bleeding in their lung. All right? Not good. Okay. So here are HIV complications at T cell count under 200. And by the way, it's called CD4 T cell, but nobody ever says CD4 T cell. It's too long. So you say CD4, you'll say T cell. Same thing. All right? So infectious, PCP, pneumocystis carinii pneumonia, histoplasmosis and other endemic fungi, miliary TB, now which is tuberculosis in someone who's immunocompetent. Tuberculosis tends to form a cavitary lesion. You look at the lung and you see a cavity. In someone who's HIV infected, it's likely to be miliary. It means a diffuse pattern. Looks like grains of sand. Very diffuse throughout. All right? So in someone who's HIV infected, you have a miliary TB pattern. You can also have a negative chest X-ray in someone who has TB, someone who has TB and HIV infected, because you need T cell counts. Important to know, because you need T cell counts for the macrophages and everything to work and cause a cavity. If you have no T cell counts, you won't have cavities, you won't have fevers, right? So that's why your index of suspicion has to be very, very high. And sometimes you don't know until you check, you do a bronchoscopy or something. PML and non-infectious wasting, peripheral neuropathy. The patient will present with tingling, pins and needles sensation, more common in the feet or in the fingers. Okay? Cardiomyopathy, their heart just gets bigger and bigger, and dementia. When you see a 22-year-old who can't remember where they put their keys, right? Think dementia. Or they're lazy, but think dementia. So PCP. It's no longer called PCP, it's called pneumocystis jirovecii, but nobody who's my age ever remembers to call it jirovecii. We still call it PCP, all right? But it's now pneumocystis jirovecii. in 20 to 40% of patients not on HIV treatment. It's usually a subacute presentation of dry cough and dyspnea, shortness of breath. Subacute meaning the person says, for the last 4 or 5 weeks, I used to walk 5 blocks to work, and now I can barely even just walk from the bedroom to the bathroom, right? The chest X-ray usually reveals an interstitial infiltrate, which I'll show you, but you may have a lobar consolidation occurring only in one lobe of the lung, a pneumothorax in severe cases. In fact, you can have someone just present with a pneumothorax, a collapse of the lung, because pneumocystis, as the name suggests, is cyst, and the cyst rupture and the lungs collapse. So you'll have a 23-year-old comes in with one lobe of their lung completely collapsed. It's not because they're tall and thin. It's also because they have HIV, and they probably smoke, which doesn't help either. Right? There's treatment available, which is Bactrim and steroids. And there's prophylaxis available, which is Bactrim only. Prophylaxis is to prevent the disease. And the patient goes on Bactrim prophylaxis if their T-cell count is under 200. There are also other secondary medicines that you can give for treatment or prophylaxis based if a person has an allergy to the primary medicine. But Bactrim is a primary modality. Here's what it looks like, a diffuse interstitial pattern. You notice here, it's very smoky looking. Here's the organism on, this is from a bronchioalveolar lavage, a BAL. And here's the cystic appearance, clear area around the organism. It's usually described as looking like a foamy exudate on pathology. Let's talk about histoplasma. The Mississippi River Delta region is very endemic for this organism. It's rarer in South Carolina, but can occur. There's a wide spectrum of illness from acute sepsis-like syndrome to acute pneumonia to cutaneous involvement. Here's an oral lesion for histoplasma, an ulcer. You have to do a biopsy or urine histoantigen. Here's the organism occurring in a macrophage, but here is it higher magnification. Here's the organism here. Let's talk about PML, progressive multifocal leukoencephalopathy. Clinical disease occurs in patients with advanced disease, and this really truly occurs in advanced disease. It's very unlikely to see someone has a very high T-cell count and have PML. Onset may be insidious or over several weeks. Clinical signs and symptoms include hemiparesis, cognitive defects, speech deficits, visual deficits, sensory deficits, and seizures. It's very atypical to see a young person presenting with stroke-like symptoms, but that's what you think of. Then the next step should be think HIV. So the clinical hallmark of disease, and this is important, is a patient with focal neurologic, well, everything I say is important, but this is just a little bit more important. Focal neurologic deficit, white matter disease, no mass effect, right? Lesions do not enhance on imaging. And I'm going to give you examples of other diseases that have mass effects or enhance on imaging. Okay? So PML is a demyelinating disease of the central nervous system caused by infection of oligodendrocytes by a JC virus, which is a papovavirus. Here's what it looks like, white matter disease. That's what the arrow is pointing to. Here it is again, white matter disease. And why am I showing you this? I'm showing you this because this shows a demyelinated foci containing atypical astrocytes, and this is a oligodendrocyte here with intranuclear inclusion. So let's talk about complications as CD4 count under 100. Some infectious ones include disseminated HSV, toxoplasmosis, Candida esophagitis, cryptosporidiosis, microsporidiosis, isospora, cryptococcal disease. I'm going to talk about these in a second. So cryptococcal meningitis. This is also was very common. It certainly still occurs. is an encapsulated yeast inhaled into the small airways where it usually causes subclinical disease. Dissemination to the CNS is not related to a pulmonary response. So someone can have very normal lungs and still have it here. Or they could have very bad lungs, very bad pulmonary disease, and don't have it here. Right? And that's important because not all diseases are like nocardia, not to confuse you, but nocardia is another fungal disease. If you have it in your lung, you better think brain. Because you'll treat the patient, the lung clears up, you send them home, and they come back with a seizure. But cryptococcal can be independent of both sides. So C. neoformans produces no toxins, evokes little inflammatory response, and the main virulence factor is a capsule. So clinical manifestations: headache, 70 to 90%, fever, malaise, stiff neck, photophobia, and seizures. You should also remember that when someone puts up clinical manifestations, it doesn't mean that when you see a patient, the patient has all of these. Someone could just have headache only, right? Or they could just have a stiff neck, or they could just have fever, or they could just have seizures, right? But certainly these are the most common symptoms which occur. Average duration of symptoms is 30 days. So someone who comes in with what seems like a chronic meningitis, think HIV and cryptococcal meningitis. Predictors of poor outcomes are altered mental status, increased opening pressure. When you do a lumbar puncture, you want a normal opening pressure. If it's elevated in the hundreds, you know, bad sign. And a white blood cell count less than 20. The diagnosis is made by CSF examination with India ink, cryptococcal antigen of the serum or CSF culture. All right? And the level of cryptococcal antigen is not indicative of severity of disease. Someone can have a very low level and be very sick, and vice versa, right? Or a marker of response to therapy. And serum cryptococcal antigen can rule out clinical disease in HIV positive but not negative patients. Because you have patients who are not HIV infected who can develop cryptococcal meningitis, particularly elderly patients or patients on steroids. They respond differently from someone who's HIV infected. That's what the organism looks like. And I made some notes that unlike histoplasma, it's more spherical, and it tends to be larger, and there's usually less budding as opposed to histoplasma. Yes. Yes, and that causes the differential staining pattern. Notice it's lighter in the center because the capsule is pretty resistant. That's correct. Okay. So toxoplasma encephalitis. Clinical presentation: focal neurologic deficit, 50 to 89% of folks, seizures, fever, generalized cerebral dysfunction, neuropsychiatric abnormalities. And diagnosis is often presumptive based on characteristic lesions, clinical course, risk strata, where your T-cell count is, and positive serology. So someone comes in, all HIV-infected patients who see the doctor for the first time get a toxoplasma IgG and IgM. If the IgM is negative, right, when you do this, then you know that the person, whatever it is not toxo, right? If it's positive, then the person can reactivate. Then you have to think toxo. Okay. Toxo is also important in pregnant women. For pregnant women who are not toxo IgG, they can get infected with toxo. And the key in the exam is cats, cat stool, cat feces, right? That's how you, when the cat poos on the ground, you walk on the ground, you catch it, right? And it can cause abortions. And women are immunosuppressed because the baby's a parasite, and that's how it stays there for 9 months. It's true. Even 18 years after that, or if you go to medical school, 24 years after that, right? You're always giving money to support. Moving along quickly. Presumptive diagnosis. Presumptive diagnosis is considered confirmed by tissue sample or response to toxotherapy in appropriate time. You see, toxo is often confused with a lymphoma. The difference is that toxo responds dramatically to treatment, very dramatically. And here it is. Patients should show clinical response, neurodeficits, but not necessarily fever or headache. So the neurodeficits should clear up, but the person might still have a fever and they might still have a headache. By day 5, half of people have gotten better. By day 7, 70% have gotten better. And certainly by day 14, 90% of people have gotten better. In contrast, patients with CNS lymphoma all had worsening of signs or symptoms by day 10. So it might take longer to get the diagnosis, to diagnose toxo, but you treat presumptively. And by day 2, day 3, the patient should be improving. If they're not improving, you have to think it's a lymphoma, all right? Here's cerebral toxo. Notice it's contrast enhancing because of the edema. Here's the lesion here, but the swelling. And this mass effect will cause a collapse here. Here's a bunch of the organism, adjacent, penetrating, all different types. Okay. Here's some causes of diarrhea. So Cryptosporidia parvum, Cyclospora catyatenensis, Acidospora belli, Microsporidia, Giardia lamblia. Now, anyone can get diarrhea, even you. But for someone who's immunocompetent, the diarrhea is usually self-limiting. For, patients with Cryptosporidia, diarrhea, can have diarrhea for months. And when I say diarrhea, I don't mean 2-3 times a day. I mean 10, 15, 20 times a day. And it just pours out. It just trails behind you. You could find your way home by walking behind it, such that the person cannot work. It's really incapacitating. Does happen. Does happen. Does happen. But you can also get non-fungal to cause the diarrhea, so Giardia, which is a parasite as well. Here's Cryptosporidium parvum. What do I want to say about that? That's what it looks like. Here is Cryptosporidial, which is smaller, and Cyclospora, which is larger. Isospora belli, and this is a modified acid-fast stain of the organism, more elliptoid, like elliptical. So HIV complications, the T cell count under less than 50. Infectious, disseminated CMV gives you retinitis, disseminated MAC, Mycobacterium avium cellulare. I believe I'm going to talk about that in a second. Non-infectious, CNS lymphoma. Disseminated MAC, usually subacute or chronic illness, characterized by fevers, weight loss, diarrhea, night sweats, and wasting. Usually occur with a T cell count under 50. When someone think of a typical AIDS patient, the stereotype of the skinny patient who's losing weight and sick, it's usually MAC that causes that. Okay. Here is the organism. It's an acid-fast thing. So it's related to Mycobacterium tuberculosis, but it's not. It's another category. The organism tends to stick together. It's a function of the glycolipids in the cell membrane. Here's just more of the organism in another stain. Right? More of the organism, acid-fast. Okay. So primary CNS lymphoma, B-cell malignancies, high grade, 73%, occurs in extremely immunocompromised hosts, T-cell count under 50, unlike systemic non-Hodgkin's lymphoma. Common signs include focal neurodeficits, altered sensorium, seizures, cranial nerve deficits. So right away you can see there's a bunch of things that cause similar symptoms, but different etiology. So lymphoma, toxo, right? 50% of patients will have a single lesion, usually in the gray matter. Toxo lesions are usually multiple, smaller, and associated with the basal ganglia and in the white matter, but the two entities cannot be distinguished by imaging alone. So primary CNS lymphoma, diagnosis is based on clinical presentation, neuroimaging, CSF studies, brain biopsy, which is sometimes almost impossible because depending on where the lesion is, right? It's good I know it's CNS lymphoma, but now you can't see and you can't talk because I took out that part of your brain, right? So it's not always very easy to do. CSF PCR for EBV is sensitive and specific. Treatment is radiation chemotherapy, and response is related to the stage of disease and control of HIV. So people basically who are on medicine have a high T-cell count tend to do better. But some of it is also based on the type of cancer. It could be very aggressive, and no matter what you do, the patient just dies anyway. That just shows lymphoma. CMV retinitis is a cause of blindness, can be sudden. There's a characteristic perivascular hemorrhage and exudate. It looks like ketchup on a pizza. It looks like a cheese pizza. Here it is. So here's the blood vessel, here's the edema and the hemorrhage. Just think cheese pizza. All right? Normally, you're supposed to look like more like here. Right? Not this and this stuff. That's your hint, cheese pizza. Okay. So brief overview of treatment. What time do we go on? Till 2 o'clock? We stop at 10, at 11. Okay. So HEART is a collective name given to the HIV medicines. And you take them all every day or you don't take them at all. Right? It's interesting that patients will be on 3 drugs and they'll figure out which one causes diarrhea and they'll stop that one. Right? And they'll try to make you feel good and tell you, but I take these 2. You just messed up royally. You take all of them or you take them not at all. Because the virus can become resistant to the medicines if you're not on the medicines. Because your level in your blood doesn't fall rapidly. It becomes subtherapeutic dose. And once the dose is subtherapeutic, the virus develops a resistance to it. But when you become an ID fellow, we'll talk more about that. All right? So here are the classes of the antiretrovirals. The NRTIs, the nucleoside reverse transcriptase inhibitors. Then there are the nucleotide reverse transcriptase inhibitors. Then there are the non-nucleoside reverse transcriptase inhibitors, protease inhibitors, and fusion inhibitors. Those 5 categories are the categories that are presently available. We're working on others that are not yet around. So I just threw in a list of all the medicines. We've come from there just being AZT to now where there is a lot of medicines, and they work. The NRTIs, please don't memorize the name of the drugs. Okay? I just put it there just for you to see that they actually exist. This is old. This is a 2004 guideline, but I got lazy, so I didn't put the 2006. But essentially what I want to take a message from this is that a patient should be in at least 2 categories of drugs. Right? So don't remember what the drugs are. Just remember the key point, at least 2 different categories of drugs in order for them to be considered to be on HEART, highly active antiretroviral therapy. There are recommendations as far as what should be chosen first, second, but that's not for your level. Okay. So as the drugs work, we have to balance how the drugs work with the long-term consequences. We have switched from where we used to say the minute someone is diagnosed as being HIV positive, that we start them on therapy, to now we say, well, gee, let's wait until the T-cell count is under 350. And we're still sort of waffling as to exactly when is the best time because of associated side effects if someone is on the medicines for a long time. We've made a dramatic improvement with the medicines. I mean, look at this. We came from where 1981, which was the first case of HIV, where the death rate just went up. I mean, it was... Y'all are probably too young, probably all of you except Peter. Where everybody else. I think I was going to forget that, did you? Where, when someone is 20, I mean, you'd worry that you're going to die from HIV because it seemed like everybody was getting it. It's just a matter of time. Then HEART came along, highly active antiretroviral therapy in 1996, and then a dramatic decline to here. But now this number is stabilized. So about, the mortality has stabilized, and we're trying to figure out exactly why is that. Nobody yet understands why or why not, why it's not dropping down back to 0. I mean, certainly new people are getting infected, but also people are taking their medicines and they're living longer. But that's been balanced with new infections, and that's the goal of public health, is to try to understand why that leveling off is occurring. So some of the complications of your HIV infected are on the medicines, a long list. Glucose disorders, lipid elevations, hyperlactinemia, bone disease, osteopenia, osteoporosis. You can get fat accumulation, abdominal obesity, fat loss. And a lot of these are disfiguring. And I have some pictures to show you in a minute. The buffalo hump, breast enlargement, breast enlargement in a man is not pretty, all right? It's not a good thing. Not a good thing to have. It's bad enough that you're taking a lot of pills for your HIV. Now we have to throw in medicines for your diabetes. Here's an example of the fat loss, lipoatrophy. Someone who never had high cheekbones before, all of a sudden have high cheekbones. So if you're trying to hide your HIV status, now everyone will look at you and tell, right? Because all the fat is gone. And someone who never exercised in their life comes in real sculptured, right? Prominent veins, you know? And you think, oh, you're working out. No, HIV, all right? Not pretty. Here it is. This is a pregnant man. Not very good, right? Not pretty. Here's a woman with a buffalo hump. And this can be very painful. It's like large breasts. You could have large buffalo hump. Very, very painful and not very pretty. So in the last dwindling seconds, I couldn't help myself. So I threw in some public health. Because y'all are going to do good in public health, right? Right? Thank you. Flatter me. So the colors in dark orange are the states that have high prevalence of HIV, and South Carolina, just to orient you, is right here. Right? Here's South Carolina. I'm glad I oriented you, that you are in South Carolina. Here's California, which has San Francisco and LA. Here's Texas, that has Houston, which are the hotbed for HIV. But notice South Carolina is dark orange. So let us count, 18.1. There's Louisiana, there's Florida, there's Georgia, there's New York, there's Connecticut, there's New Jersey, there's Delaware, there's Maryland, there's D.C., which rivals some of the rates in Africa or Southeast Asia, and South Carolina is 10th. In 2004, South Carolina HIV/AIDS prevalence was 10th in the nation, even though by population we have only 4 million people. We're 26th by population, so we're 10th. In fact, South Carolina has been in the top 10 since about 1996 or so, for the last 10 years. So you're like, even though HIV has, the diagnosis has stabilized, when you go to the wards, you're definitely going to see a lot of HIV-infected patients with opportunistic infections that I just spoke about. So it's going to be very important for you to know those. In South Carolina, it's 47% African-American males, 26% females, 20% white males. Here's a risk factor. Men who have sex with men, HIV, the rate started, got labeled in a bad way, in that we kept putting everyone in groups and exempting ourselves, right? Initially, we thought it was men who have sex with men. But look, in South Carolina, it's 33%. In South Carolina, heterosexual is 30%. Now do the math. 30% isn't much different from 33%, right? So for someone who's heterosexual saying it's a gay disease, they're wrong, right? The common factor here is unprotected sex, regardless, because if you're a man who has sex with a man, you have only one partner or use a condom, you're not going to get HIV, right? But there's also 24% of people who don't know how they got it, right? A woman goes in to have a baby, she gets an HIV test, she's positive. She's been married the last 10, 15 years. Goes to church every Sunday, or in medical school studying, one boyfriend, you know. She got it, right? Because she probably didn't think she was at risk. Here is this is South Carolina. This is for African American prevalence. Here's Richland County. Here's Horry County. Here's Charleston, Beaufort. So you know where you go to get your groove box. I just want to orient you that you have to be careful where you go, because HIV is very common in South Carolina, these dark orange colors. So this is what it is for African Americans. Here it is for Caucasians. Right, here's Richland County, here's Horry County, and here is Charleston or Myrtle Beach, so be very careful. Let's talk about transmission. It's highest in blood and body cavity fluids. Semen and vaginal fluid is moderate, but also in breast milk. Can you breastfeed if you're HIV infected? Can you? Okay, very good. But should you breastfeed? No. Very good. So you can, but you shouldn't. All right? Urine. Actually, last year I spoke about the common terms for this, and someone in their evaluation said, you shouldn't talk like that in front of ladies. So I'm going to do it again. Urine. Golden shower. If part of your sexual practice involves golden shower where someone urinates over you, and you have cuts in your skin, the HIV is found in the urine, and you can contract HIV like that. Saliva. If you kiss someone, you can contract HIV, or oral sex, all right? And when I say kiss, I don't mean little dry kisses. I mean back in college where his tongue is all the way in your esophagus for 2-3 hours, that kind of kiss. And also remember that dental hygiene in South Carolina is very poor. So the virus has to traverse a disrupted membrane. And if you have periodontitis or any sort of gum disease, it puts you at risk. Tossed salad or eating feces, fecal oral sex is also a risk for HIV or Salmonella, Shigella, and so on. And it's also found in sweat and tears. Not high concentration, but definitely present. So HIV transmission factors, highest if you have AIDS, an STD or genital lesions that breaks the integrity of the membrane. Frequency of unprotected sex. If you have unprotected sex once, it can happen, but if you go to a bar and have sex with everyone in the bar, very likely. Circumcision, there's big discussion going on now that circumcision could be protective because the foreskin has a lot of receptors for HIV. But it's not yet final, so don't go out and have your doctor shorten it. What they did was they looked at Muslim countries versus Christian countries, and in Muslim countries where they're all circumcised, there are lower levels of HIV as opposed to the Christian countries. But what they didn't say is that in Muslim countries, you might have 10 wives or 20 wives, depending on how rich you are. But those are the only 10 or 20 you have. So we know who you're having sex with. In the Christian countries, you have one wife, but you have sex with 20 other people that you don't know very well, right? So behavior has a big part to play with it. So, but the jury's still out. I'm sure there's probably some protective element there, but it's also compounded by behavioral risk factors. HIV in pregnancy, 20% occur during the development of the baby, 80% actually occur during labor, and 14% during breastfeeding. So it's never too late to start HIV medicines because the big chance of being infected occur during labor. AZT is pretty protective. Before AZT, about 1/3 of infants were born positive, but with the new therapy, it's less than 1%. In South Carolina in 1996, there was about maybe 15 infants who were born HIV positive, and last year it was about 2. And those moms are usually people who present to your doctor's office and the baby's halfway out, right? No prenatal care. This is the last slide, and then Dr. Brian will come on. But I love showing this slide. When we have HIV-infected patients, new or established, in the beginning, for newly diagnosed patients, we ask, do you talk about condom use? Do you provide risk reduction counseling? Do you talk about illicit drug use? Or do you talk about HIV disclosure to partners? Providers do it about 83% to 72% of the time. But when the patient becomes established, we stop asking. It falls from 17% to 27%. I can tell you that it's students I see in undergraduate, that the boyfriend they have this week or girlfriend they have this week is very likely not the same boyfriend or girlfriend they have next week. So if you were to ask someone, are you married this month, and never ask that question again, you assume that everyone gets married and live happily ever after. Or even if they're married, that they're not necessarily happy and are doing stuff that would put them at risk for HIV. So when you go in your practice, always think of asking follow-up questions. All right? Thanks for your time. Any questions? Good. See you next year.